Hello again, friends. We're going to focus here on inflammatory bowel disease. If you ever spent some time with a gastroenterologist, you'll see that they see this a lot, both in the inpatient setting and the outpatient setting. These patients will need chronic following. Generally, gastroenterologists will see these patients at least on a biannual basis. And then a lot of times these patients will also have flares, in which case you'll see them in an inpatient setting. So this is something that affects a lot of people, and it really impacts their quality of life. So you need to be well aware of this. So inflammatory bowel disease can affect any part of the digestive tract, and it can also affect the biliary tract up to the gallbladder. So here's a vignette. A 35-year-old man presents to the emergency department complaining of bloody diarrhea. He says that he's been having diarrhea for the past 2 weeks, but he was prompted to come in because this afternoon he noticed a maroon color in his stool. He says that he has abdominal pain, but is unable to point an exact spot. He rates it as a +6 out of 10, and he's been trying to control it with Pepto-Bismol to no avail. He's lost 10 pounds since his previous visit to the ER for a broken thumb 6 months ago. His vitals are stable, but he's slightly feverish. Blood pressure 125/83, heart rate 80, respirations 15, temperature 100.5. So this is a patient with inflammatory bowel disease. We don't know what kind he has, but the tip-off to the fact that he has inflammatory bowel disease should be the fact that he has chronic diarrhea, so diarrhea lasting longer than 2 weeks, and the fact that it's bloody. So inflammatory bowel disease is an idiopathic inflammatory autoimmune disease process. So it's autoimmune because the patient is producing factors that are attacking the body's own tissue, and it's inflammatory because there is actual inflammation in the affected tissue. And it's idiopathic because we don't know what causes it. There are genetic factors, but this can happen in anybody. And of course it involves the GI tract. The most common age of onset is in the 20s and 30s, but this can happen in teenagers, it can happen in kids, and it can happen, it can show up in 50 or 60-year-olds. Really, it can happen to anybody, but the most common age where this shows up in a person for the first time is in the third or fourth decade of life, so the 20s and 30s. You tend to see inflammatory bowel diseases more in Caucasians than in African Americans or in Hispanics, but of course you can see it in anybody. So don't let that throw you off. I'm just telling you some basic overall factors. It's more common in Caucasians, and particularly there's a preponderance in Ashkenazic Jews. Inflammatory bowel disease is increasing in incidence, and there's a higher incidence in developed countries. So we don't really know what to make of that information, but we do know it exists. People with inflammatory bowel disease, if it exists for longer than 10 years, they do have an increased risk for colon cancer, and of course there's going to be a reduced quality of life. As you can imagine, having bloody diarrhea and going to the hospital frequently is going to reduce your quality of life. And there's two types of inflammatory bowel diseases that we're going to talk about, and that will be Crohn's disease and ulcerative colitis. So the symptoms of inflammatory bowel disease. So right now we're talking about both Crohn's and ulcerative colitis. You're going to have chronic abdominal pain. So this is an abdominal pain that came on recently and remits. This is abdominal pain that the patient can, when they come into the ER, they can say, hey, this has been going on for, since last August or since last year. It comes and goes. Or I've had this sort of mild pain for the last few weeks, and now I'm coming in because I have bloody diarrhea. Another symptom, of course, is the bloody diarrhea, hematochezia. Mucus in stool is also another, not necessarily common finding, but a more specific finding. Diarrhea, of course, is common because of the inflammation in the bowel. The large intestine can't absorb fluid. Systemic symptoms, because this is an autoimmune disease, you're going to see systemic symptoms, so fever, weight loss, sweats, malaise, arthralgia, nausea, and vomiting. The systemic symptoms really point towards inflammatory bowel disease, whereas you can get bloody diarrhea and chronic abdominal pain from a lot of things. The systemic symptoms, particularly the fever and weight loss, are really what will point towards inflammatory bowel disease when they're accompanied by the abdominal pain and the bloody diarrhea. And then also there are extraintestinal manifestations. You don't necessarily see these very often, but when they exist, again, they point towards inflammatory bowel disease. So I sort of ordered these symptoms in order of the most common to the most specific. So chronic abdominal pain, bloody diarrhea, those are the most common. You're also going to see fever and weight loss. That's also very common. And then the extraintestinal manifestations are a little less common, but they are more specific. When you see these things along with your more frequent symptoms, that really points towards inflammatory bowel disease. So the extraintestinal manifestations can manifest in the skin, eyes, joints, and liver. There's two different kinds of skin manifestations. We're going to see some pictures of those in a little bit. Erythema nodosum and Pyoderma gangrenosum. In the eyes, you can get any kind of inflammation on the front part of the eye, so ileitis, scleritis, and episcleritis. In the joints, you can get an inflammatory arthritis. So patients will come in when they have inflammatory arthritis. That could be the only symptom, for instance, and they'll have a redness and pain in their joint. And when you do an aspiration of the joint, you'll find white blood cells. In the liver, you can get primary sclerosing cholangitis. A lot of times you hear that only comes with Crohn's. This primary sclerosing cholangitis can come with Crohn's or ulcerative colitis, so it can come with any inflammatory bowel disease. And then gallstones are actually a common manifestation of inflammatory bowel disease. What I put here in italics are the more common extraintestinal manifestations. So the history in any patient with inflammatory bowel disease, a lot of times it's going to be non-contributory, but a lot of patients with inflammatory bowel disease, definitely a minority, but a good chunk of them will have a family history of inflammatory bowel disease or rheumatoid arthritis. And for diagnosis, the gold standard is going to be colonoscopy with biopsy. That's the only way you can diagnose inflammatory bowel disease. It is a diagnosis on biopsy. That's the only way you're going to be able to differentiate Crohn's from ulcerative colitis. Okay, so this is, we're just going to take a look at some of these skin manifestations. This is erythema nodosum. So what these kind of look like are just sort of bruises, redness. So erythema nodosum. Erythema comes from the Latin word for redness, and nodosum is just a node. So it's little red nodes, and that's what these kind of look like. They look like kind of like bruises or red nodes, if you want to go by the name. So this is erythema nodosum. Most commonly, it occurs on the shins and on the calves. This is one on the fingers. That's not as common. So here is Pyoderma gangrenosum. Clearly this is much different. Pyoderma meaning fire skin, gangrenosum meaning gangrene or dead tissue. So this is an ulcerating disease. I'm going to say you don't see this very commonly, but this can happen in patients with Crohn's or ulcerative colitis. So this is just ulceration of the skin, and it can really happen anywhere. So for erythema nodosum, generally you're not going to have to do anything about that. For Pyoderma gangrenosum, in addition to treating the Crohn's disease or ulcerative colitis, you're going to have to consult with a surgeon or dermatologist. So this can be either scleritis or episcleritis. The difference between scleritis and episcleritis, they look the same. You've got inflammation of the cornea. But with episcleritis, the difference is you don't have pain. With scleritis, you do have pain. So that's how you separate the two. Okay, so how do we differentiate Crohn's disease versus ulcerative colitis? What's unique? Until now, we've been talking about things that are common to the two of them, which are a pretty significant amount of things. So what makes Crohn's disease and ulcerative colitis separate? For Crohn's disease, this affects the entire thickness of the GI tissue, so it affects all the way from the inside, close to the lumen, and then all the way to the outside. So this is transmural, the entire thickness of the tissue. And it also affects the entire GI tract, so all the way from the oral mouth tissue all the way to the anus. So entire tissue, entire GI tract. With Crohn's disease, one of the most prominent things that make this unique are fistula, and fistula are just due to inflammation, and it's a communication between one lumen to another lumen, or one lumen to another cavity. So this only occurs in Crohn's disease, and some examples of this would be enteroenteric. So enteroenteric would be bowel lumen to bowel lumen. Enterocystic, so it would be bowel lumen to bladder. Enterovaginal, which would be bowel lumen to the vagina. And perianal, which would be bowel lumen to the anus. And a lot of these fistula can manifest in, if it's perianal, it can manifest in anal leakage. The other kinds can manifest as infections. Aphthous ulcers or canker sores do occur in increased incidence in patients with Crohn's disease. It can occur in the esophagus and stomach as well. So these are going to this could manifest as dysphagia or as odynophagia, and these are just patients with what look like regular old canker sores, which you've probably had, but they're more severe. Of course, not all patients with Crohn's disease have these. These are just unique to Crohn's disease. And then Crohn's ileitis is an inflammation or ulceration of the terminal ileum. So remember that we talked that Crohn's disease infects the entire GI tract, whereas ulcerative colitis only affects the large bowel. So if you have disease in your terminal ileum, which is part of the small bowel, then you know that this is Crohn's disease. For ulcerative colitis, we know that this is limited to the large bowel, and primarily this affects the rectum. You can have ulcerative colitis of the entire large bowel, that's certainly possible, but ulcerative colitis in most cases tends to only affect the rectum and the sigmoid, but it can affect the entire large bowel. It never affects the rest of the GI tract though, just the large bowel. And with ulcerative colitis, what you can see, what comes up in the USMLE, not going to say it happens so much in real life, but you get this, what they call tenesmus, which is an urge to defecate, but there's no stool, and then a passage of mucus. That tends to be more common in ulcerative colitis, but it's not exclusive. With ulcerative colitis, primarily what you should know is that it's limited to the large bowel, and primarily the rectum. So as far as diagnosing Crohn's disease versus ulcerative colitis, the only way you can make a definitive diagnosis is colonoscopy with a biopsy. So you put in the colonoscope to look at the tissue, get your impression, and then you get a biopsy. And that biopsy will give you a specific result that will tell you if it's Crohn's disease versus ulcerative colitis. If you remember back to step 1, you had to know what does Crohn's disease look like versus what does ulcerative colitis look like under the microscope. For step 2 or 3, you don't need to know that. But you do have to know that you need a biopsy to make the definitive diagnosis. So for Crohn's disease, some of the things that can help you diagnose this is patients with Crohn's disease will tend to be ASCA positive. So what ASCA stands for is anti-Saccharomyces cerevisiae antibody. I can't say that we do these that much in real life, but on the USMLE, this is very prone to come up. On colonoscopy, macroscopically, you'll see skip lesions. So what skip lesions are basically what it says, lesions that skip. So you'll see healthy tissue, and then diseased, inflamed tissue, and then healthy tissue alternating. And a lot of times this is going to encompass the entire large intestine all the way to the ileum. Crohn's disease is not very commonly going to just be in the sigmoid and rectum, and then the rest of the large intestine is fine. Patients with symptomatic Crohn's disease are going to have diseased tissue throughout their entire large bowel. And frequently, you'll see diseased tissue in the terminal ileum. As far as ulcerative colitis, they'll also have a marker for their disease, but theirs will be ANCA. So remember, ANCA is what we saw in Wegener's granulomatosis. ANCA is also seen in ulcerative colitis. So ANCA is anti-neutrophil cytoplasmic antibody. And on colonoscopy in these patients, you'll see confluent inflammation. So rather than the skip lesions where you see some healthy tissue, some diseased tissue, on colonoscopy for ulcerative colitis, you're going to see a confluent inflammation. All the tissue is going to look relatively similar, and then you get to your healthy tissue. So you'll have inflamed tissue and then healthy tissue. You're not going to have alternating regions. You're not going to have your skip lesions. Of course, if the ulcerative colitis occurs in the entire large bowel, then you would see the large bowel entirely inflamed. So you can see why we really do need to get a biopsy. Our macroscopic impression can only give us an idea. Biopsy is what we need to make a definitive diagnosis. So here's a colonoscopy. So this is, on the left here, this is a normal patient. So this is, I think this would be the transverse colon here. Usually you know transverse because you have triangles. That's what my attending taught me. But this is healthy tissue. It's pink. You can see capillaries here. So this is healthy tissue. This looks like it's the sigmoid. So this is healthy tissue. This is clearly not healthy tissue. So this in the middle, here you can see that there's some healthy tissue right here, this pink tissue, and then you got some red inflamed tissue with a lot of polyps. This is I think this is also transverse or ascending colon. So this is Crohn's disease. You have polyps and inflamed tissue along with normal tissue here. Polyps can occur in either though. And then this is also Crohn's disease. This looks like the sigmoid colon, and here you have healthy tissue and then little spots of inflamed tissue here. So this is Crohn's disease. And these are all confirmed. So they look like, I mean, you still have to get the biopsy, but these are confirmed with biopsy. I wouldn't show you these otherwise. But these are good examples of what Crohn's disease and ulcerative colitis look like on colonoscopy. So this is ulcerative colitis. This is the rectum. Here are the sigmoid. I'm not exactly sure. I think this is the rectum down here and the sigmoid. It doesn't really matter. This is, you can see confluent inflammation. So you don't have any regions of healthy tissue. It's all inflamed tissue. And this is all inflamed down here too. So this is ulcerative colitis, confluent inflammation. So when you're doing colonoscopy, you're sending it from the rectum all the way over, if you can, to the cecum, which is the first part of the large intestine. If you can, you want to retrograde your valve into through the ileocecal valve so you can get a look at the ileal pouch, which is the last part of the small intestine, because you want to see, is there any diseased tissue in the ileum? If there is, then you're going to know that this is Crohn's, because with ulcerative colitis you will never have diseased tissue in the small intestine. So this is Crohn's ileitis. This is ulceration, inflammation of the ileal pouch. So this is the ileum here. And you know you hit ileum because this is nice shiny mucosal tissue. So this is Crohn's ileitis, much shinier and glimmery than your large bowel. Okay, so how do we treat inflammatory bowel disease? Crohn's disease and ulcerative colitis are very similar in how they present. They're very different disease processes, but again, they're very similar in how you treat them. So that's a good thing because it means less things to memorize. So the first line of therapy are going to be the mesalamine derivatives, or commonly known as the ASAs. These are the first line of therapy for long-term treatment. So when the test question asks you in a patient, it gives you a vignette, patient with Crohn's disease or ulcerative colitis, and asks you which of the following is the best pharmacologic therapy in this patient, best initial pharmacologic therapy, your answer is going to be ASAs. These ameliorate your symptoms. These are going to be the long-term therapy for patients with inflammatory bowel disease. There's 3 different ones that are most commonly come up well, in real life and on the boards. Pentasa works on the entire GI tract. So the way you can think of it is pent meaning 5 parts. So you can think of your esophagus, your stomach, your small bowel, your large bowel, and your rectum. So these work on the entire GI tract. Well, whose disease affects the entire GI tract? That would be Crohn's disease. So Pentasa is best for Crohn's disease. Azicol and Rowaza, these both primarily work on the rectum and anorectal area. Azicol is, I believe, an oral medication. Rowaza is an enema. So these are both good for ulcerative colitis, but they can also be given to patients with Crohn's disease too. So those are the ASAs. I think I heard it once, read in a book once. Azicol is like ass-a-col, and so that's how you know it works in the rectum. And then Rowaza starts with R, and that's how you know that works in the rectum. So anyway, whatever helps you remember it. Okay, steroid-sparing agents are used as conjunctive therapy when the ASAs alone are not sufficient. So what the steroid-sparing agents do is they inhibit inflammation by cytotoxicity. So these are like chemotherapeutic agents, and they're cytotoxic, so they prevent inflammation by just their inherent cytotoxic properties. So the two that we use are 6-mercaptopurine and azathioprine. So they're called steroid-sparing agents because a lot of times in the patients who don't respond to ASAs, we're going to have to put them on steroids to get their disease process under control. Over time, we don't want these patients to be on steroids long term, so we put them on these drugs, these steroid-sparing agents, long term. So steroid-sparing agents are also long-term treatment. Biologics are monoclonal antibodies, and so these are newer drugs, and they selectively block tumor necrosis factor alpha. Again, these are conjunctive therapy. You're always going to have these patients on ASAs first, and particularly these drugs are used for Crohn's that come with fistulas. So infliximab is the one you're going to see on the USMLE, but there's other ones, adalimumab, and so forth. So the steroids are used primarily for flares and acute therapy only. They're not used for long-term. You don't want to use these for longer than 6 months if you can avoid it. The ones you'll commonly see are budesonide, which is a PO. You'll see prednisone, which is also PO, and methylprednisolone, which is IV. So some of the adverse effects, primarily the ASAs are relatively well tolerated, so you're not going to see you shouldn't see adverse effects from those, at least on the USMLE. For 6-MP and azathioprine, the steroid-sparing agents, drug-induced pancreatitis is, I'm not going to say common, but it does happen. If you do get drug-induced pancreatitis, you're going to stop these drugs if the patient is on them. Myelotoxicity is another thing. It's reducing in frequency because we have a way of preventing it, and that is to get a TPMT phenotype test. So don't ask me what TPMT stands for because I don't know. Look it up. TPMT, what this is basically an enzyme that breaks down one of the byproducts of these drugs. So 6-MP and azathioprine are cytotoxic, which is fine, but if it lingers around in the body long enough, you can get myelotoxicity, and that would be bad. So you want to make sure that this patient has TPMT enzyme. And so what you get is a TPMT phenotype. 10% of patients, approximately, are going to be TPMT negative, which normally would be fine, but if you give these patients 6-MP or azathioprine, they're not going to be able to metabolize the drug as fast, and so they can get myelotoxicity. So in a patient that's TPMT negative, if they don't have TPMT enzyme, you don't start these drugs ever. You can't use these drugs. But most patients should be TPMT positive, meaning they do have the enzyme. I will say that Asians and Pacific Islanders do have an increased, they have they're more likely to be TPMT negative. So that does happen. Infliximab, with any of the anti-TNF alpha drugs, any of the biologics that we use, One of the adverse effects can be reactivation of latent TB. So in any patient, before we start infliximab or any of the anti-TNF alpha drugs, we want to get a PPD before starting it on a patient. With steroids, you see all the very typical adverse effects of long-term steroid use, and this is a reason why we don't want to use steroids long-term and why we would rather use 6-MP or azathioprine long-term. And the adverse effects of steroids are weight gain, buffalo hump, hypernatremia, hypokalemia, metabolic syndrome, and so forth. Now, if a patient has an active perianal mass or a fistula, we want to treat that mass, that fluctuant mass, usually it even looks like an abscess, with metronidazole and ciprofloxacin. So we're going to drain the mass. If there's ever a mass, you should consider that you do need to drain it. But if there's a fistula present, you would want to start antibiotics. So active perianal mass or fistula, you've got to start antibiotics. But if there's a perianal mass, you want to drain it too. Surgical therapy is curative for ulcerative colitis, but not for Crohn's. And of course that is because ulcerative colitis only affects the bowel, the large bowel. And so if you take out the large bowel, which you can do, and you would just have your small bowel going into a bag. You can do that, and that's fine. And if you take out the large bowel, then your ulcerative colitis will be cured because that only affects the large bowel. But for Crohn's, it's pointless to take out the large bowel because you can get Crohn's disease anywhere. So surgical therapy is curative for ulcerative colitis, but not for Crohn's. That doesn't mean that there aren't surgical therapies that can be used for Crohn's that can ameliorate the symptoms, but it wouldn't be curative. Patients with Crohn's can get strictures in their large bowel, and that can be, so surgical therapy can be used in patients with Crohn's, but it will never be curative for patients with Crohn's because Crohn's affects the entire GI tract. So long-term complications of inflammatory bowel disease. So this is, again, now we're talking in general. So this is ulcerative colitis or Crohn's disease. One of the major long-term complications is colon cancer. And so there's an increased risk for colon cancer when the disease has been present for greater than 10 years. So starting at around 10 years after diagnosis, you're going to want to start routine surveillance for colon cancer. And so the symptoms of colon cancer include bloody stools, change in stool caliber, constitutional symptoms, and pallor. You can see here that these are very similar symptoms to what you would get in inflammatory bowel disease itself. So it's going to be really important that you get surveillance colonoscopy every 1 to 2 years or as indicated in patients with inflammatory bowel disease. And of course you're going to get it even more often if there's polyps present. So very important that patients with IBD are getting colonoscopies on a somewhat regular basis. Toxic megacolon is primarily a complication of ulcerative colitis, and what you would see here is a very large colon on abdominal film. But the symptoms, when they come in, they're going to have an abdominal pain, but it's going to be not the abdominal pain that you see in IBD. It's going to be a very, very, very severe abdominal pain. It's going to be a generalized abdominal pain, but it's going to be the type of abdominal pain where they're not going to let you touch them. These patients will also have fever, and they will also be distended. So patients with just regular old inflammatory bowel disease flares, they don't have distension. They may have fever and they may have abdominal pain, but it won't be incredibly severe abdominal pain. They won't rate it out of 10 out of 10. And they'll, of course, never have distension and they'll never have shock. With toxic megacolon, you can perforate, and so you have to keep an eye out for shock. So severe abdominal pain, distension, shock, fever, those are all part of toxic megacolon. And this can be diagnosed on abdominal plain film, and what you'd see, of course, is colonic dilatation. The treatment is going to be surgical resection. You would resect the entire large bowel, and then you will treat with antibiotics accordingly. Another thing that can happen with, rather than toxic megacolon, is you can get just a general perforation of the bowel. That will look pretty similar clinically, but it'll look different on your plain film. I'll show you pictures of that. Strictures are segmental narrowing of the large bowel. So this will present as an obstruction. So you're not going to have a fever. You're not going to have extremely severe abdominal pain. You can have distension, but this isn't going to present as much of a surgical emergency as toxic megacolon. This is going to be more obstructive picture. So you're going to have a patient that's got nausea and vomiting. They haven't passed stool in a long time. They haven't passed gas in a long time. That's a sign of obstruction. You can diagnose this with barium enema, and this can be treated with, actually, you would not want to do a barium enema on this patient. Scratch that out if you wrote it down. You will diagnose them with just regular old barium studies. So you'll give them a barium meal, and you'll be able to see if there's a stricture. Don't do a barium enema. So barium studies, and this can be treated actually with endoscopic dilatation, but it may require surgery. So as far as endoscopic dilatation, what you would do is you'd take your colonoscope, you would go in, and you would essentially do the same thing as what you do for the esophagus when you have strictures in the esophagus. You'll take a balloon and dilate it out. Of course, this can require surgical resection of the strictured segment. For fistulas and abscesses, fistulas are communications from the bowel to another cavity. Abscesses are just focal infections. For these, you're going to just use vigorous medical therapy. Primarily, you're going to use the biologics. For abscesses, you're going to drain them, and you'd also use biologics there too. And a lot of times, these are going to result in surgery. So for the abscesses, you're going to have to drain them. For the fistulas, you're going to do some kind of surgery. I don't know. I'm not an anorectal surgeon. Just know fistula and abscesses may result in surgery. What I put here in red are surgical things. So colon cancer, not so much a surgical issue as much as a medical issue or an oncologic issue. But toxic megacolon, strictures, fistula and abscesses, you're going to want to have your surgeon on call. So this is toxic megacolon. You can see here that you've got a very, very, very large bowel here extending from the descending colon all the way down to the beginning of, I think this is the appendix right here actually. So you've got a very, very, very large colon, very dilated colon. So this is toxic megacolon. And this is a patient that is going to, they're going to need their entire colon resected. This is an intestinal perforation. So how you know this is an intestinal perforation versus toxic megacolon is, one, you don't see the dramatic dilation of the colon. Of course, you don't have a megacolon because all you have is a perforation. But what you do have is you have air coming out of the large bowel and into the peritoneal space. And so what you'll get is air underneath the diaphragm. Subdiaphragmatic air would indicate an intestinal perforation. So you see that here on the abdominal plain film. It's more prominent on the chest x-ray because you can see the diaphragm going way up into the chest space. So this is an intestinal perforation. Can also happen with inflammatory bowel disease. So toxic megacolon and intestinal perforation. Okay, so what do we do then? We've talked about the therapy. What do we do in general? Let's sum it all down for patients with inflammatory bowel disease as far as we treat them. The initial drug of choice is an ASA. So we want to have these patients on long-term therapy with an ASA. Generally, it's going to be Pentasa, but you can also use Roaza or Azicol. If there's inadequate response to the ASA, you can start the patient on an oral corticosteroid. Generally, you don't want a patient on an oral corticosteroid for more than 6 months. Budesonide and prednisone are your oral corticosteroids. Once the symptoms remit, and generally the symptoms will remit within a couple weeks, once the symptoms remit, you're going to taper your steroids down. You can't just stop steroids right away. You have to taper them down. So you'll taper your steroids once the symptoms remit. If the symptoms persist, so you started the patient on an oral corticosteroid, but the symptoms have persisted for 4 months, then you're going to want to start the patient on a steroid-sparing agent. Now, I said that we don't want to keep the patient on a steroid for more than 6 months. So why do we start tapering them at 4 months, because it takes the steroid-sparing agents, 6-mercaptopurine and azathioprine, about 2 months to reach levels that they'll be effective at. So we want to start tapering the corticosteroids at 4 months and starting the steroid-sparing agents at that point, so that by 6 months they're on only steroid-sparing agents. If the patient has refractory disease, you can consider using a biologic. Remember, for steroid-sparing agents, you want to get a TPMT phenotype, and for biologics, like infliximab, you're going to want to get a PPD for TB. For the flares, so this is when the patient comes into the ED because they've got significant disease, bloody diarrhea, and so forth. You want to start IV fluids on these patients and get routine labs. You're going to also want to get a C. diff toxin assay, because this can be another cause of bloody diarrhea, another cause of fever, something that looks just like colitis, Clostridium difficile colitis, C. diff colitis. So you're going to want to get a toxin assay on patients that come in like this, and you're going to want to get a pregnancy test in women of childbearing age. Of course, you're always going to want to be vigilant for acute complications, so obstruction, perforation, toxic megacolon, and you'll investigate accordingly. So if there's toxic megacolon or perforation symptoms present, then you're going to want to have a surgery consult, and you're going to want to consider immediate surgery. So those are things you have to be vigilant for, not saying that they're common though. Once the patient is stabilized and you've gotten these, you've started the IV fluids, you've gotten your labs, you're going to admit them, you're going to start IV corticosteroids, so IV steroids because this is a more acute problem, and so you're going to use methylprednisolone, and their diet can be as tolerated. If they're vomiting frequently, which can happen in patients with Crohn's flares, if they're having severe diarrhea, you're going to want to have them possibly on IV nutrition. Hyperalimentation is okay. So in patients that are having severe symptoms, you're going to want to have them over their normal amount of calories. That's fine too. But just their diet can be as tolerated. You don't have to worry about NPO. You don't have to worry about a specific diet. Regular old normal diet. The only exception to that is, of course, if they are a candidate for surgery, then you are going to want to have them NPO. So particularly if they have an obstruction, then NPO, as in any time when you've got a patient that's pre-op. We're going to assess the progress in these patients. So after about 2 to 3 days on IV steroids, the symptoms should begin to remit. And at that point, you're going to gradually switch them to PO corticosteroids in anticipation of discharge. Budesonide and prednisone are your corticosteroids that you would use. And if the symptoms are persisting, then you would want to consider possibly surgical options. And, I'll do some slides on surgical therapy of bowel disease at a later point. So we're not talking about everything with inflammatory bowel disease, just primarily the medical therapy. And that is it.